When Dr. Christie asked me to come and talk to you about fungal keratitis, I said, "Oh, can I talk about something else?" Because I certainly approach this with a lot of humility. I think the collective experience of treating fungal keratitis in this room is very, very impressive. And I certainly don't pretend to have that kind of experience myself, although I do see some cases. Is this better or this better between the two? Okay. So I, again, have financial disclosures with grants. So we know that fungal keratitis is a very, very important public health concern. We know that these patients have a worse prognosis, and we also know that we have limited treatment options. The most effective treatment having been developed in the 1960s, being topical natamycin. And this is a problem that's actually being recognized more in the United States. I've been in conversation with some folks at the CDC who've become concerned that fungal keratitis is actually becoming more common in the US. And we really don't know why that is. There have been a number of outbreaks in LASIK clinics of this novel organism, Purpurocilium lilacinum. And we think that this is probably environmental exposure. So this organism is actually being used as a biopesticide in the US for organic farming purposes, and somehow is making it into clinics. And then, contamination of LASIK things, instruments in order to do LASIK. They don't know which ones are causing outbreaks of this infection. Of course, there's also concern that there's been climate change, and that as the planet gets warmer, fungal keratitis and the fungal organisms are becoming more prevalent also in the United States. So the story of the treatment of fungal keratitis also starts at Arivend. And the original mycotic ulcer treatment trial was a collaboration between UCSF and Dr. Prajna here at Arivend. And they randomized patients to topical natamycin versus topical voriconazole. And of course, found that those treated with topical natamycin had better outcomes than topical voriconazole. And that was particularly true of Fusarium versus Aspergillus. But we also know that natamycin has a lot of limitations, right? It just doesn't penetrate very well. As you can see in this histologic slide of a corneal button, all these organisms in the posterior stroma are still very alive and present, and that's despite the topical natamycin treatment. So we continued, and this is where I started to join the group studying this. We added oral voriconazole to see if that would improve things. And really what we found was there was no difference. And in fact, no matter what we threw at these patients who had severe keratitis, whether it was oral or topical, 50% of them went on to have a corneal perforation or therapeutic graft. And we even looked at those patients, and most of those patients ended up losing their eye. So it's a very, very, very severe disease. So what are we going to do beyond topical natamycin? We've tried topical voriconazole. We've tried oral voriconazole. We have a few other things that we're interested in. A lot of people have mentioned intrastromal voriconazole, interestingly here. And I'm curious to talk more about this later because right here in Pondicherry with Dr. Seema, we did a study where we randomized patients to topical natamycin versus intrastromal voriconazole plus topical natamycin. And we found that those who got intrastromal injections of voriconazole were 3 times more likely to perforate. And so I feel that that is a contraindication to doing intrastromal voriconazole. And I say that with humility because I know you guys are on the ground treating all of these patients. So I'd love to hear more about your perspective. I know that at Ames, they are doing intrastromal injection with topical natamycin, but it's a proprietary formulation that doesn't have a particulate matter. And so that may have better effects. But I do think that this is something that we could discuss afterwards. In my mind, I'm not using intrastromal voriconazole at this time. We also became interested in corneal cross-linking. So we randomized, in collaboration with Dr. Prajna, patients to corneal cross-linking. This was riboflavin versus topical natamycin. And of course, everyone got topical natamycin. And unfortunately, the patients had 3 lines worse visual acuity when we gave them corneal cross-linking. And this was also statistically significant. So unfortunately, we have to cross that off our list as well. So now I'm taking some consolation from Winston Churchill, who said, "Success comes from going from failure to failure without a loss of enthusiasm." So we have failed to find the better treatment, but we will still be enthusiastic and looking for another one. And we recently completed the REAGIR clinical trial here at Aravend, along with Unifesp in Brazil. And this was a collaborative effort between Dr. Lietman, Dr. Prajna, Dr. Ana Luisa, and Dr. Denise, and myself. And in this trial, we randomized patients to rose bengal, PDT, which is basically photochemically activating rose bengal, just like we do with riboflavin, but using a green light instead. And this was technology that was developed in the lab of Jean-Marie Parel in Bascom Palmer Eye Institute. And Guillermo Amezcua has treated a number of patients clinically and done kind of the initial studies that have shown that there's something of interest here. So we did a large trial where we randomized over 300 patients here at Aravend and at Unifesp in Brazil. And we followed them for 6 months. And what we found was overall, in terms of visual acuity, there was no difference. So you can see here on the x-axis, we have time. And on the y-axis, we have visual acuity in logMAR. So what is important to remember about logMAR visual acuity is less is more. So 0 logMAR is actually equal to 20/20. And you can see that everyone does get better, but there's no significant difference between those treated with sham or those treated with rose bengal PDT. But interestingly, when we looked at subgroups, we found that fusarium ulcers had about 2 lines better visual acuity when treated with rose bengal PDT. And this was, it's hard to explain, but our interaction term was statistically significant, which gives us the right to look by organism. And this is essentially a statistically significant result. So then we looked at corneal perforation or the need for therapeutic penetrating keratoplasty, and we found that there was no difference in statistically speaking. But when we looked by organism, we found that actually if you got treated, if it was an aspergillus ulcer and it got treated with rose bengal PDT, there was more than a four times the hazard of perforation among those treated with rose bengal PDT. So that was statistically significant. So it just appears that there is something different fundamentally about aspergillus and fusarium. And I think that's something that's very, very interesting about fungal keratitis. I don't think we can lump it as one group of organisms anymore. I think we're going to have to start thinking of them as different organisms and different treatments. And it may come down to something as simple as aspergillus is green and we're using a green light, and green light's not going to penetrate into this green organism. And fusarium's white, and so we're getting in. Or it may be something completely different, and I think we really need to figure that out. So I think there's still a question about rose bengal PDT for fusarium ulcers, and we are in the initial stages of developing another RCT to kind of look at this specifically in fusarium ulcers. And we still have, unfortunately, these patients who we are trying to rescue from the terror of a therapeutic penetrating keratoplasty, where they have terrible outcomes and get glaucoma. And so I think there's a number of things. Dr. Christie has just spoken about adjunctive tacrolimus, which I think is something that's very interesting and that we should continue to study. And how do we decide who's at risk and who needs these types of further intervention? Who should we be watching more closely? Repeat cultures have been really helpful in my hands. And we've shown in the literature as subgroup analyses of mutts that if you have repeat cultures, you have 7 times the risk of needing a TPK. So those are patients that are at very high risk, and you want to follow them more closely, be more aggressive with their therapy. And some of the things that I'm working on right now, I have found in my hands that conjunctival flaps can be very, very useful. So this is a patient with a pigmented fungus infection who was on topical steroids for a failing DSEK transplant. And it doesn't look like a very severe infection, but I think all of us recognize that if a patient's on a lot of steroids and then you withdraw steroids, then it's just going to blow up and be such a horrible infection. So I reduced the steroids. I didn't totally stop them. And I did a pedicle conjunctival flap very early in the disease process. And it was remarkable. Within 3 weeks, this patient looked like this, which, I think I've found that in severe infections like acanthamoeba and fungal keratitis, I'm very interested in studying conjunctival flaps as a potential treatment. You're bringing in the body's own immune system and defenses to get rid of these infections. Just wanted to briefly mention glue, cyanoacrylate glue. If at all possible, I really try to glue and prevent somebody from going for a TPK as much as is possible. And we know it has antimicrobial properties. We know it can restore anatomic integrity and reduce the chance of severe infection like endophthalmitis. So I would really, if you can, try glue before going to the OR. And then the other thing I think is really, really important is we don't have to do a full transplant each time. There's a lot of reasons to consider doing a partial TPK. And this is a patient of mine where you can see that she had a full thickness perforation, tried glue, it didn't work. So there was a lot of melting here. So we had to do a large crescentic graft. And what's really nice about this is you get a nice seal because most of this is just a dulk, except for that perforation, pre-existing perforation. So you have a really nice seal. You have a decreased rate of graft rejection. And also, even if you do have graft rejection and complete graft rejection, this patient can still see around this graft rejection. So this can be compatible with really good vision. And then, of course, you always have the option of later doing an optical PK if you need to. So in summary, just topical natamycin is still the best treatment for fungal keratitis that we have. Repeat cultures can be very helpful in determining who are high-risk patients and need more attention and more therapy. And the truth is that surgical intervention may be necessary for these patients. And I'm trying things like conjunctival grafts before jumping to a therapeutic transplant for myself, for my patients. And then just wanted to thank all the collaborators at Unifesp and here at Aravend who have contributed to this work over the years. So thank you for your attention.